good morning, everyone. Welcome to this webinar on genomics. It's actually the second seminar on the theme of genomics for future health. And this time our focus is on reproductive genetic screening. As we all know, the technology, advances in technology in genetic testing and screening is now becoming so readily available that it's finding its way to every area, including reproductive medicine and also early screening in the very early stage of reproduction. So today we have two distinguished speakers, Professor Ainsley Nielsen and Dr. Kelvin Ho from Hong Kong. Let me start by briefly introducing the two speakers. Ainsley is a professor of bioethics at Sydney Health Ethics, University of Sydney. Her research focuses is on the ethical aspects of genomics and human reproduction, with the aim to ensure technology to develop and use appropriately and fairly. Ainsley's current research projects are looking at new genomic technologies in prenatal testing, reproductive carrier screening, and implementation of genomics in publicly funded healthcare systems. Her research has generated over 150 academic, policy, and general interest publications. And our second speaker will be Dr. Kelvin Ho. Kelvin is Associate Professor with the Faculty of Law and Co-Director of the Center for Medical Ethics at the University of Hong Kong. His research is on the governance of health and biomedical technologies, including human genome editing, stem cell research, health technologies based on artificial intelligence and data analytics. He is also on the ethical board, member of the Doctors Without Borders and a member of the Access to COVID-19 Tools Accelerator Ethics Working Group of the WHO. And we also today have thank you for our two discussants or commentators, Professor Kevin Mills and Ms. Josephine Johnston. Professor Mills is Director of Monash Bioethics Center at Monash University. Her research addresses ethical issues arising from innovative reproductive biomedicine technologies. In her currently funded projects, she is looking at genomics for preventing mitochondrial diseases, expanded non-invasive prenatal testing, epigenetics, uterine transplant, and commercial interest in IVF. She has extensive record of academic publications, and including free author books. And our second commentator is Ms. Josephine Johnston. She is the Director of Research and Research Scholar at the Hastings Center, an independent bioethics research institute in New York. And she is also with the University of Otago's Bioethics Center in Dunedin. She works on the ethics of emerging biotechnologies, particularly as used in human reproduction, psychiatry, genetics, neuroscience, and her work has appeared in medical, scientific policy, law, and bioethics journals, including really the first tier journals. She holds degrees in law and bioethics from the University of Otago in New Zealand. So this time I'm sorry I'm rushing through all the introduction a little bit, so hoping to keep the flow of the workshop more continuous subsequently. So without further ado, may I invite Ainsley to speak. She is going to talk on the ethical issues in large-scale reproductive genetic carrier screening programs, a view from Australia. Ainsley, time to you.
Thank you for that very kind introduction and for having me here today. Hello, everybody. It's lovely to see you, albeit virtually. In my presentation over the next half hour, I'm going to talk about some of the ethical aspects that have arisen in the context of reproductive genetic carrier screening in Australia. And Australia is a hybrid public healthcare system, meaning we have both public healthcare provision and private care as well. And before I go on, I'd like to acknowledge Dr. Lisa Dive, who unfortunately can't be here today, but Dr. Dive has worked with me in this project. And so this is as much her work as it is mine. I'd also just like to acknowledge that I'm in Australia and I am on Aboriginal land in Australia, which is unceded Aboriginal land. And I'd like to acknowledge the traditional custodians of the land in which I sit today and pay my respects to any Indigenous people wherever you might be in the world. So by way of introduction, carrier testing is a type of genetic test that determines the likelihood whether someone is going to go on to have a child with a serious childhood onset, autosomal recessive or X-linked condition. Now, there's nothing new or fancy about that. That type of testing has been around for about 50 years. But until recently, this type of testing tended to take place in two contexts. The first was when a family knew that there was a genetic condition in their family, and so members of that family might like to know whether they too have a chance of passing on that condition. And that's known as clinical carrier testing. And then also this type of testing took place in certain populations who had a particular ancestry or ethnicity. And this was called carrier screening, but usually was only for a single condition or a small group of conditions. So what has happened in recent years to change things such that we're having conversations about carrier screening all over again? So over the past sort of 10 to 15 years, DNA sequencing has become much cheaper. And this has been combined with increased knowledge of variation in our genome and how our genomes vary from each other's, and also relationships between genes and disease or genes and phenotype. And this large-scale ability to offer information has enabled this information to begin to be offered to a much broader range of individuals. And this can happen in one of two ways. The first, which is actually much less common at the moment, is where a government decides to invest in this technology and underpins a screening test offer to anyone of reproductive age in their population. Now, there's maybe one or two countries that have thought about that in any serious detail at this time. And then much more commonly, there are commercial providers where public programs are not available. I should also just add, there are two main ways that this information can be offered, either as a test to a person on their own or as a test to a person in collaboration with their reproductive partner. I'm not going to go into the distinction between those today. It varies around the world, and there are sort of ethical benefits and drawbacks to each of those approaches. It's just beyond the scope of my presentation. What this is now enabling is universal screening. And by universal screening, I mean screening to anyone of reproductive age who is interested in having the test, not based on whether they have a particular family history or whether they are a member of a particular ethnic group. And so we are offering this type of information to more people, and we are offering this information about lots more genetic conditions than we used to. And the picture there is just of one of the commercial products that is now available. So I said that I would be speaking about a view from Australia. And what is happening in Australia at the moment is there is a research project taking place called Mackenzie's Mission. This is funded by a particular health funding stream in Australia known as the Medical Research Futures Fund. And it's called Mackenzie's Mission because our health minister, Greg Hunt, the federal health minister in Australia, named this project after a little girl who died at 7 months of age from spinal muscular atrophy type 1. And her parents had their daughter completely unaware that she would go on to develop this condition, and they asked why they weren't told that this testing was available, because it was available, just not with any public funding. And they appealed across a broad range of factors to members of parliament on the background of many years of advocacy from geneticists and other families who had lost children to a range of serious childhood onset conditions. And the timing was right, and Greg Hunt made an investment in this project. And so this project is ongoing at the moment. It's wrapping up in 2022. And around 8,500 couples are being recruited to participate. Now, this is in the context of around 300,000 babies being born a year in Australia. So this is a very small offering in comparison to what a future program could look like. So I emphasize this is a research project at this stage. Mackenzie's mission is undertaking couple-based screening. So I mentioned that distinction earlier, and they're looking at around 1,300 genes that would detect around 750 conditions. But because the testing is taking place on a couples basis, the actual detection rate per couple, that is the percentage of couples that are told they might have a higher chance of having a child with a condition, is less than 5%. And the goal of this program is to generate evidence to inform what a future national screening program might look like. And that's the website of the project if you'd like to know more. I just want to emphasize too, when we say couples, this doesn't necessarily mean a heterosexual couple who are married to each other. There is provision in this program to also allow people who are forming families in numerous ways to participate. And so there's capacity to register donors, etc. So there are a wide range of ethical issues that come up in population scale reproductive genetic carrier screening. And I've just popped them all in little bubbles on this slide here in an absolutely non-systematic way. Some of these have to do with how the test is offered, and a lot of these actually map on to carrier testing as it has always taken place. And some of the issues are about what we do when we start to offer this type of testing at a really big scale. And they're the issues that I'm going to talk about today. And I'm talking about testing a large number of people with government funding. So I'm going to talk about, what ethical paradigm might be useful here, whether such testing generates concerns about eugenics, and if so, how we should respond to those, and which kinds of genes we should screen for. So let's take each of those three things in turn. I'll first talk about ethical paradigms. And when I'm talking about ethical paradigms, I'm not going to get too hung up on vernacular here, but I'm really talking about here, should how we think about this type of initiative be informed more by considerations that come broadly from clinical ethics, or should it come from considerations of public health ethics, or perhaps something in between? So the first thing we have to do when we look at this is to think about what type of test reproductive genetic carrier screening is. Is it a clinical test or a public health screening initiative? And at least in Australia, this caused some consternation within Mackenzie's mission when it first commenced, because a lot of the personnel involved, the structures of setting up the study, the laboratory structures, had all come from the clinical realm. And so the laboratory infrastructure, in fact, the actual kind of testing that is being done, the sort of molecular level of the test, is exceedingly similar to how that process might take place in clinical practice. But this is being offered at large population scale and to a large range of people who may not necessarily have a particular family history of any genetic conditions. But what we found in the early days of Mackenzie's mission was there was a very strong influence of a clinical paradigm. There was significant concern, for example, about missing a case and getting sued by research participants. But at the same time, what this project is being set up to do is to come up with something that is feasible at population scale. So that cannot involve taking detailed family history, for example. So when we start to think about reproductive genetic carrier screening, we can see that it has many things in common with what might be called more a screening or a public health test. That is, that there is a single test that is offered. It's not a multiple range of tests. You don't go and come back time and time again. The test is the same, no matter the background that you have. The type of information that's given isn't tailored to the individual. There is obviously interactivity for the online resources, but there's no sort of in-depth one-on-one pre-test information provision. There is public funding for this, which is something I'll come back to throughout my presentation, which could be said to add legitimacy or influence into the test offer. And there is no clinical history taken before a test takes place. And the interpretation and reporting of variance, sometimes we've had a lot of conversations about this within the project, and sometimes you have a gene variant that might need some more information in order to be able to make a decision about whether something is pathogenic or not. Now, in a clinical context, you're much more likely to push that further than you will in a screening context. So there is an air of erring on the side of caution and reporting less rather than more in order to avoid providing information that is going to effectively overdiagnose an individual or couple. So Lisa and I, in our work, thought about this and we've written on it, and we claim that reproductive genetic carrier screening is a certain kind of public health intervention. But from that, you then have a question of, well, if it is a certain kind of public health intervention, does that mean we need to think about it in a more public health ethics way of thinking than, say, a more traditional clinical ethics paradigm, which emphasizes reproductive autonomy? Now, this is a much condensed version of quite a long paper, but I provide the citation to the paper at the end, and I'm also happy to answer questions about it. But ultimately, the form of public health ethics that Lisa and I endorse is one that claims that individuals live in a social context, and we cannot overlook that social context. Our sphere of engagement as a person in the world is one where our private lives and our public spheres are interdependent with each other. We have a lot of social determinants that impact our lives, and they also impact our health. And so the education we receive, our income, etc., as listed on the slide here, are all things that influence our health and should not be overlooked. And I think certainly when it comes to genomic screening in populations, levels of health literacy are really important too. And a lot of these things are sometimes out of individuals' control. And so we know that a health intervention can be something that can benefit an individual person, but it can also benefit collective good. And so we need to pay attention to the social as well as the individual. And in the form of public health ethics that we endorse, we talk about how values such as equity, reciprocity, and solidarity are all incredibly important. And by solidarity, I mean this idea of positively identifying with our fellow human beings and driven by our sympathy and empathy and understanding of the plight of others than ourselves. And that this should be reflected in the way that we engage with other human beings. And so I've mentioned reproductive autonomy as well. And sometimes typically a public health paradigm is seen as a prevention paradigm. Now, obviously, a prevention paradigm alone is going to be quite problematic when it comes to reproductive genetic carrier screening. But Lisa and I argue that we can promote autonomy, but in a screening context. And so actually, neither a straight up clinical ethics paradigm or a public health ethics paradigm alone provide a good justification for ethical population offers of reproductive genetic carrier screening. Instead, we need to promote reproductive autonomy, but also recognise the social context in which this test takes place, including some of the issues people might experience in accessing services, whether that be health or social care, other broad social and health inequalities that will influence how people engage with this type of testing, what the normative implications of the test offer are. And I think that's really important, and I'll come back to that in the next section on eugenics, in the sense that the very offer of reproductive genetic carrier screening itself could actually influence the context in which a decision to have this screening is made. And this will influence how the test is perceived and concerns around routinization, but also what is on the list of things that we test for and what message that sends, both to whether people should have the test, but also to those living with the conditions that are being screened for. And also we need to think about collective values as well as merely individual values and well-being. So what we need to do is to embed considerations, of course, of reproductive autonomy, but also relevant public health ethics values into how we design and offer reproductive genetic carrier screening programs. So what do we mean here? Lisa and I argue for what's called public health pluralism. That is a public health approach that promotes more than one value. And a list of those is on the slide here. So some of these are things that you might want to sign up to more than others. We took this list from a previous paper by Professor Stephen Wilkinson at Lancaster, but we augmented his list to make it what we felt was more amenable and more appropriate for reproductive genetic carrier screening. And ultimately, this is about trying to balance the individual and collective aspects of reproductive genetic carrier screening while avoiding a normative implication that testing is the right thing to do. And we should evaluate this program not on how many people have this test, but how many people are offered this test. And we should not be aiming to reduce incidence. We can notice what happens to the numbers of children born with certain conditions, but that itself should not be a measure of success of the program. And that actually creates a segue into the second issue, which I'll consider, which is eugenics. So when Mackenzie's mission was publicly announced, accusations of eugenics were made almost immediately. And so Lisa and I knew from the start that this was something we wanted to talk about. Eugenics can be defined as a range of practices designed that we use hereditary to promote desirable characteristics. Now, we all know what happened in the 20th century, and so I won't go into that in detail, but ultimately there were numerous problems, with those atrocities that were committed, not least the fact that what constituted a desirable person was extremely narrow, and the methods that were used were highly inappropriate and violated bodily integrity, were racist and discriminatory. And medical genetics has spent a very long time trying to distance itself from that history. So is reproductive carrier screening itself eugenic? So we know that it is a way of selecting the kinds of children that will be born, and it has a list of genes that are made as a test offer. I should add, in Australia at least, under the Mackenzie's Mission program, it is a single test offer. People engaging in the program don't have the opportunity to pick and choose conditions, and that is a pragmatic judgment based on resourcing. And so, reproductive genetic carrier screening is obviously distinct from eugenics, but at the same time, it has been criticised as being eugenic in either intent or outcome. And the image on the slide here is an example of one piece of writing that has come out in Australia since Mackenzie's mission has been taken place. So one response that is very common to make is, look, this is not the same as eugenics because it's all about choice. People can choose freely whether they want to participate in reproductive genetic carrier screening or not. And you can reflect on whether it's right for you. And when you receive your results, there's lots of different things you can do, and you're not expected to do any of them. You can just take that information and use it to inform, whatever you want going forward. Is this enough? This is what Lisa and I asked ourselves. Is this appropriate? And we've also published a paper on this that came out relatively recently in the Journal of Medical Ethics. So we claim that response, that it's all about individual choice, is an appropriate response, but it's not enough. Because offering reproductive genetic carrier screening for certain genetic conditions might lead to less acceptance and accommodation for the disability and difference that these conditions give rise to. And if we only focus on individual choice, then we are overlooking both the collective impact that those choices might have on society, but also how society itself influences the choices that individual couples or people make. And so if we are to engage seriously with the eugenics critique of reproductive carrier screening, we can't merely say that it's about individual choice. Instead, we also need to emphasise the social and normative context in which these reproductive decisions occur. And we need to look at the fact that reproductive genetic carrier screening can actually shift those norms, because in Australia at least, what we're looking at is a publicly funded test offer with a large gene panel that contains a lot of different things to screen for. And so this diagram really just represents that interrelationship between individual choices and the social context and how they influence each other. And in our paper, Lisa and I come up with 4 suggestions as to how we can respond seriously to the eugenics critique. Now, I'm just looking at time. I don't think I'm going to have time to go into these in huge amounts of detail, but ultimately, none of these things on their own is necessarily novel, but I think they need to be brought together to seriously engage with the context of eugenics. And that includes looking at the potential acceptance of disability and difference, to pay attention to how these are framed in reproductive genetic carrier screening. And there's definitely a testimonial injustice question there about hearing voices of people who live with the conditions that are being screened for. The process to select what genes are screened for needs to be transparent, robust, and revisable, but it also needs to be representative. And we must account for inequity and disadvantage in our implementation, and routinization must be avoided at all costs. And I use routinization in a pejorative way there. I appreciate that not everybody sees that term as a pejorative term. So seeing here now, as we've had a couple of points here about gene selection, let's turn to the final section of the presentation. And this is about severity. Now, I was a member of the committee that selected the genes to screen for in this project, and the process for that selection has been published, and it has been subject to a bit of criticism, including by people who were members of that group. And I don't know if we would do it the same way again. We had to do it very early on in the project, and the learning since that time has been really significant. But one of the very big driving considerations is severity. Not sure if you can hear, there's an extremely loud kookaburra right outside my window.
It's okay.
Yeah, it's nice showing where I am sitting right now. So gene selection for reproductive genetic carrier screening, not just in projects like Mackenzie's mission, but this happens in a lot of things, and also in genetics much more broadly too, I should add, often includes a statement, and indeed I did it on my first slide, that the conditions being screened for are severe or serious and could lead to suffering is something else that often gets used. And this provides a signal that the condition is something that a person or a couple would be expected maybe to take steps to avoid. And it could be used, the reason we do this is to try and distance reproductive genetic screening from frivolity, from a non-serious things, because if we're testing for frivolous things, then we really are potentially in trouble from the perspective of eugenics or disability and difference, and devaluing people who live with those conditions. But severity is a really complex and under-theorised concept, and there's just sort of 3 things here that I'm going to talk about. The first one is around impairment and serious impairment. Now, I think we need to be really careful here not to overlook the social environmental context of impairment, in that how much impairment is actually clinical and how much is because of a social context or the social environment where a person is placed, and how much of that is due to each of those things. And so we also need to recognise that impairment can be physical or cognitive. A second element is associated with severity is whether a condition is life-limiting. And this is, if something is life-limiting, it's typically thought to be severe, but what impact on life expectancy is where we should draw the line. And what do we do when a condition is very variable? And how do we make that determination? And if a condition is life-limiting, is that in and of itself enough to make a condition severe? So we can see there's lots of questions arising here. And the third one is, the third factor that's often discussed is suffering. But how do we conceptualize suffering, and whose voices do we listen to, and how do we quantify that? This is very difficult. And so what we see is that severity is quite contested. It's contested both normatively in terms of, how we actually conceive of and discuss it, but also how the conversation is occurring is currently a little bit problematic. So the literature until recently has been full mainly of clinical voices. It really almost beggars belief that no one has talked very much to patients themselves. And a notable exception here is recent work by Felicity Boardman in the UK. There's also a lot of literature out there trying to quantify severity using algorithms or indexes. And again, I think this is very much about the clinical features of a condition, not so much about what it's actually like. And so we're very much overlooking the experiential factors and the social environment when it comes to talk about severity. And so we've got all of that complexity about how the conversation is taking place. And we've also got complexity in the concept itself. It's a very evaluative or appraisive concept. It's quite complex. It's quite slippery, and it's subject to change over time. And a big example of that is spinal muscular atrophy. In fact, the condition that Mackenzie of Mackenzie's mission died from, because there are now 3 treatments which, if administered early enough, have very dramatic impacts on quality of life and life expectancy. So we can't always predict what's going to happen, which makes severity very difficult to handle. So how do we work with severity? So we need to look at, severity isn't going away anytime soon. We do need to sort of work with this concept the best we can. One thing we need to do is to definitely have epistemic diversity in how we talk about it, and we need to incorporate these views into policy and decision making. We need to accept that there is going to be inherent uncertainty in this concept with lots of layers and dimensions. And we need to acknowledge and respond to this complexity. And we need to pay attention to the work that severity is doing and talk about that critically. And we might need to do things like classify around the severity of a condition to talk about whether we want to screen for it or not in reproductive genetic carrier screening. But then we might need to separate that from the impact of that condition on a person or family for decision-making purposes. So this concept might be used in different ways in different contexts, and that makes policymaking incredibly challenging. Okay, so in conclusion, when we're talking about reproductive genetic carrier screening at population scale, using countries like Australia as an example, I've claimed today that it is both a clinical offering and a public health program, and the ethical response to it needs to draw on elements from both of those domains. And we need a nuanced public health ethics paradigm that focuses on plural values. We do need to account for the eugenics critique, and we need to actively work to counter this, not just make claims based on individual choice. And we are going to screen for severe conditions, but we need to acknowledge that that concept is quite slippery. And we need to reflect that there needs to be broad testimony in how we actually understand severity, and that values in that might be diverse. So thank you so much. That is the conclusion of my presentation. That is a picture of me with very different pre-COVID hair. And that is a picture of Lisa, and that's how to contact us. And I'd just like to acknowledge that we've received funding for our work from Mackenzie's mission, but also from the University of Sydney through my school and our Deputy Vice-Chancellor Research. And I'd like to acknowledge all of the other researchers in Mackenzie's mission with whom we've worked very closely and have learned a lot from. And just as the final thing, I'm very happy to make these slides available, but this is a list of the outputs of the work that Lisa and I have done, and also a couple of the outputs from the project consortium as a whole. Thank you.
Thank you, Ainsley and Lisa as well, for that very rich discussion of the topic based on the serious thinking process that is taking place in the research project on population with reproductive genetics in Australia. Thank you. We will have our second presentation together before we go into the discussion. So may I next invite Dr. Kevin Ho. He is going to speak on responsible implementation of expanded prenatal genetic testing in Hong Kong and Singapore. Whose job is it? Calvin, time to you.
So let me start off again by thanking everyone for the participation, and most definitely to Dr. Au as well as Ms. Joey So for the wonderful opportunity to speak on this important topic. It's extremely humbling, of course, to speak after Ainsley, who is clearly an expert in this field, and certainly a privilege as well to receive comments from not only Ainsley, but also Catherine as well as Josie, all of whose work I greatly admire. So thank you so much for this wonderful opportunity. So very briefly, I think in terms of the overview, I'm going to speak about NIPT. So happy to say that there's quite a bit of rather pleasant and coincidental overlap with what Ainsley has discussed, and also happy to say that my position is very similar to hers, as you'd see. So I'd like to consider in particular the sort of concerns that may arise as we shift from NIPT, as we currently see being applied, and its move towards an expanded application, particularly in terms of the greater amount of information that is being made available, particularly through the application of next generation sequencing technology. So in light of this change, I thought it would be important to think about the extent that that expanded NIPT ought to be made available to individuals, women in particular. And if so, what are some of the concerns and also limits that perhaps may be necessary in response to some of the harms that have been highlighted in the literature. Some of you may be familiar with the sort of work that I do, so I'm especially interested in the relationship between ethics and law, and also to see how the law fits into quite a bit of the ethical discussion that we've heard from Ainsley, for instance. So, as you find, I do see the law as having a particular role, particularly important role for that matter, in balancing individual interests or rights for that matter on the one hand, and with collective interests, taking into account technologies like NIPT having much broader public health sort of implications, as we've heard from Ainsley. Of course, that said, NIPT is a very specific application of a particular genetic test, whereas Ainsley may be referring to a more programmatic sort of application. So for this presentation, I want to focus on developments in Hong Kong and Singapore. I wouldn't have time to go into the comparative dimension that essentially relating to the situation on mainland China and also in the US, England, France, and Germany. So I'll just reference some of the literature, and for those who are interested, you're most welcome to look that up. But I will try to extract some salient points and to see how they relate to the present discussion, particularly in thinking about the role of law in response to some of the ethical concerns that we have already heard. So of course, one of the important implications will be on this notion of reproductive autonomy, already mentioned by Ainsley. I'll speak very briefly about regulatory changes that may follow. So also in response to technology beyond NIPT. So I'll speak a bit to that as well. So a broad overview in a sense of what I will discuss today. So members of the audience may be familiar with NIPT. So as you know, this is essentially a technology that analyzes cell-free DNA of a fetus that's extracted from maternal plasma. As you'd see in terms of the statistics, it's extremely sensitive, able to pick up trisomies 13, 18, and 21 in particular. So its accuracy is impressive with a relatively low false positive rate. So which is why it has been considered and applied in screening programs in many different jurisdictions, including here in Hong Kong. So NIPT, importantly, does not present any procedure-related risk or risk of harm to the fetus compared with some of the other more invasive prenatal diagnostic procedures like amniocentesis or CVS for that matter. So in terms of the evolution of NIPT, you see it's a relatively recent technology, having emerged, first emerged from around 1997, and then making an important debut in this part of the world from 2011 onwards. So of course, quite shortly after that, there's been quite a bit of discussion about this notion of an expanded application, at least not so much in terms of the application itself, but in terms of the sort of information that could be derived from NIPT. So starting from around 2015 onwards, or at least from what I understand of the literature, there is the use of this particular technology to offer additional information on rare conditions. So you'd see here, conditions that would be, for instance, rare autosomal trisomies, structural anomalies, microdeletions, as well as duplication syndromes, and also, interestingly, associated maternal malignancies. So we're now in the early stages of the application of NIPT for single gene disorders as well. Of course, that will present other issues, but we will focus on some of these rare conditions like the rare autosomal trisomies for the purposes of this presentation. In the light of this technological development, I thought it might be helpful to remind ourselves of the objective of prenatal genetic testing, which has been set up by the American College of Obstetricians and Gynecologists as this. So essentially to detect health problems that could affect the woman, fetus, or newborn, and provide the patient and her obstetrician or gynecologist, or for that matter, other obstetric care provider with enough information to allow a fully informed decision about pregnancy management. So of course, with this particular goal in mind, we can think about how well the technology itself is meeting its objective, and particularly in terms of eNIPT, what might be some of the added concerns. So in terms of looking at the discussion or the debate, of course, you've got some people who are very much in favor of eNIPT, while you have others who are not. So as I understand the situation in some forums, the debate is quite divided. So almost equal number of obstetrician or gynecologists within a clinical setting voting in favor or otherwise against the broad use of eNIPT. So as you see here, some of the concerns, well, let me start with the advantages then, actually. So in terms of the advantages, of course, you get more information. You might be able to better explain particular conditions such as miscarriage or fetal loss. You have got more comprehensive knowledge of fetal chromosome abnormalities, some of which the woman herself may not be aware of, and there could well be longer-term population health kind of benefits. But of course, there are a number of important concerns here, primarily relating to, of course, a very small high-risk group to which these conditions will affect. And very importantly, at this point in time, as far as these rare conditions are concerned, there is a very high likelihood of false positives. So this could give rise to undue anxiety and surveillance or follow-up kind of activities. And of course, all of these will have very important cost implications and could well be a strain on many health systems, particularly where antenatal counseling may not be done as effectively as we hope, starting, of course, with, in many health systems, a lack of genetic counselors. So, so some important concerns there. So in Hong Kong, as you see, for Down syndrome screening, there is an algorithm set out by the health authority here. And from 2010 onwards, you'd see a conventional screening for Down syndrome or trisomy 21 in this particular form. Of course, you'd see here a combination of biochemical tests and other procedures. Of course, if a woman is found to be of high risk, then of course invasive prenatal diagnosis will be conducted. So we see this, and of course, importantly, from 2011 onwards, you see NIPT being introduced. But what's interesting, of course, in Hong Kong and also in Singapore is that while the technology itself is available to patients. It's not available within a public hospital setting. It tends to be done within a private healthcare setting. So that would be involving referral to private healthcare institutions. And of course, importantly, as this technology is being offered, it could be used in combination with massive parallel sequencing technology. So there we have quite a bit of information that could be derived in the process. So happy to highlight here a paper by Olivia Ngan, who works with Dr. Au. So I think some very important insights from this research, highlighting that essentially the way that NIPT is being looked upon. So because of the very low risk, and here I mentioned NIPT is not eNIPT, not the expanded version. So just looking at NIPT for Down syndrome screening. So you see that it's because of its very low risk nature, there hasn't been a lot of attention that's being paid to properly informing women in the process. So there tends to be a reliance, as Olivia and her colleagues have found, on general information pamphlets. Should any discussion take place, they tend to focus on concerns or matters relating to termination of pregnancy. So they also find that there is a lack of clarity in terms of referral between the public and private sectors. I'm not sure if there has been any significant improvements from the sort of concerns that they've highlighted. My own impression is that perhaps not from the time that this paper was published. And of course, very important concerns with out-of-pocket payment, because of course, following referral to the private sector, the cost of this intervention will increase. So in Singapore, the situation is not very different, although our health systems do differ. So unlike Hong Kong, Singapore does not have a free healthcare system. So all patients will have to contribute to the cost of their care. So either as private patients or as subsidized patients in, broadly speaking, public hospitals. We don't really have this notion of a public hospital, as some of you may be aware, although it operates on, these hospitals do operate very much like public hospitals here in Hong Kong. So for Down syndrome screening, in terms of the algorithm, very similar to Hong Kong, and you'd see roughly the cost for conventional screening, and where NIPT is concerned, being offered in a private setting, you'd see the cost significantly increasing from that of conventional screening. So you'd see the price range would be Singapore dollars 1,100 to 2,500. So that would be a little more in Australian dollars. So with this particular development, of course, what's interesting to see is that the procedure that's being offered here thus provide quite a bit of information, including information on fetal sex, if the patient so requests for the information. So while we're talking about NIPT, but looking at the sort of information that could be returned, it's very much in the domain of eNIPT. So what is in fact available would be expanded NIPT within an essentially private sector kind of setting. And I think I shall point to another research explaining why this is the case. So in this particular paper, there are some important differences in terms of access to the technology that's been highlighted, so done by a number of my former colleagues. So you'd see here from this particular study that women in Singapore generally show a preference for test safety, whereas clinicians, interestingly, tend to prioritize test accuracy above all other attributes. So I think this relates well to what Ainsley mentioned in terms of some important differences between a clinical focus on the one hand and what might be patient preference or patient wishes on the other. So when offered a direct choice of NIPT or for the more invasive diagnostic procedures, or for that matter, neither test, we'd find that for women who are aged 35 years and older, and those with previous miscarriage, or who know that a child might have some possibility of being born with Down syndrome, would very likely choose NIPT. But then there is also some differences in terms of race. So it was found that Chinese women tend to prefer NIPT, whereas Indian women, for that matter, would prefer a more invasive procedure. But what I thought was extremely interesting would be the finding that in general, women wanted comprehensive information. So many would in fact choose an invasive procedure presenting some risk to the fetus if it could give them better access to more information. So there might be some justification therefore for providers, of course, these are the labs offering NIPT, to provide to have an expanded sort of panel of conditions that could be tested for, as we have seen previously, given that there is demand for this. So of course, a huge concern with consideration as to whether women are adequately supported. So I think it's fair to say, whether in Hong Kong or Singapore for that matter, obstetricians tend to be responsible for informed consent. We already noted in Olivia's study that there are some serious limitations there. Similarly, the case in Singapore. There's also a challenge in thinking about what does non-directiveness mean in terms of counseling. So and of course, practically, this means that sometimes women may be provided with so much information and left without support in terms of how to work through the information and to decide in the sort of social cultural conditions where they find themselves. So a study in Hong Kong has been referred to in terms of the ability of women to appreciate the nature of the information, particularly in terms of the rate of false negative or false positive that the results may present. So we have some sense of this in Hong Kong, but there is, as far as I know, no comparator in Singapore at the moment. So we really don't quite know how well women are coping with a huge volume of information that's provided to them should they decide to have access to ENIPT. So in a recent paper that's published in AJOG by Michelle and Benjamin, I've had some discussion with Benjamin in 2019, interestingly, so before this was published. They argue that parents should have access to information that could be useful during the pregnancy, but testing for non-medical information should be limited. So from this particular position, they have, as we shall see shortly, provided an approach and a typification of information that could be shared with women who undergo testing with ENIPT. So the arguments have essentially been based on reproductive autonomy, parental rights, disability rights, and rights and interests of the fetus or potential child, arriving ultimately at the position that the government, the US government in particular, does not have a compelling state interest in regulating prenatal genetic testing, whereas this really should be the responsibility of medical professional organizations. I wanted to highlight this because I take a different view from them on this particular point. I agree that there is insufficient justification to say that ENIPT should be prohibited or should be disallowed. It was for a brief time NIPT, as we shall see, on mainland China. Of course, then subsequent developments meant that individuals did have some access to NIPT on the mainland. So I think it's an important consideration there. We do see this being taken up in real-world policy, but I think it's problematic to say that this is essentially the responsibility of medical professional organizations for reasons that I shall explain. So if we were to look at developments in different parts of the world, we don't see this as happening. But just going back to the sort of framework that they've set out, so they essentially argue that based on their typification of the information that could be derived from ENIPT, there should be certain information that physicians and counselors should recommend to all women, others that should be presented in somewhat more neutral ways, and then finally, of course, information that should be restricted. So I tend to think that this is a very tall order for professional organizations. Clinicians in the audience may differ, and I'd love to hear your thoughts on this. Rather, I tend to think that it is, in terms of the appropriate implementation of such an approach, it will require sustained collaboration, not only between patients, patient groups, and clinicians, but also the state, taking into account the sort of very important social values and public health considerations that we have already heard from Ainsley. So these sort of collaborative dynamics ought to be within any sort of policy or implementation, upscaling for that matter, of a technology like NIPT. And we see this in a number of very important developments around the world, looking at the regulatory governance of the technology. So a very helpful paper recently published by our colleagues from eTalks, Adeline and Ruth. So they advanced this observation on the governance of NIPT. So, and I quote, so although reproductive autonomy is valued in each country, so they were studying the situation in England, France, and Germany. So these were the countries. So it is understood and implemented differently, with a strong focus on informed consent and choice in England, a focus on medical information and protection in France, and a focus on the balance between the right to know and not to know in Germany. So my sense is that this observation will hold for eNIPT in these various jurisdictions. So going back to Michelle and Ben's position, so they, to be fair, did not focus on regulatory culture, but their analysis was essentially taken up based on analysis of guidance documents from professional organizations, these being some of them. Haven't got time to look into or to discuss this specifically, but we can query whether some of these documents will apply to technology at NIPT. So some of the references being made to secondary findings, for example, so we can discuss whether, for example, the appropriate management of these sort of information should just be left to patients and their providers. But again, this is one point that I'll be keen to have your thoughts on. I do think it's helpful to highlight that because some of the discussion has been taken up in a very recent best practice guidance that's been issued by the Hong Kong Academy of Medicine. So the position, it seems to me, is not very different from the position advanced by Michelle and Ben. So the regulatory governance, at least as presented in the document, resemble the arguments. And therefore, if we just go with this particular document and looking at the broad regulatory structure in Hong Kong, seems to resemble that of England and the US. So there is a code of practice on reproductive technology and embryo research that's been issued by the Council on Health Reproductive Technology. But of course, this document, by my reading of it, tends to be focused on IVF and related technologies rather than on NIPT. So it's still not very clear. In terms of thinking about access to information, what the position in Hong Kong is, it's very much left to obstetricians and gynecologists to decide in collaboration with their patients, but that's what we find the situation in Hong Kong at the moment. It's quite different looking at mainland China, as I've mentioned. So interestingly, between 2011 and 2014, so several cell-free DNA-based tests were made available, although many of these would have been too costly for patients with limited financial means. So interestingly, in 2014, Chinese regulators became concerned and suspended all prenatal genetic testing, including NIPT, until, of course, new regulations were implemented. But sorry, before I go to the next point, of course, the concern here would be the highly variable quality of the test, and then, of course, unsubstantiated claims by commercial providers. That, of course, would have also been similar concerns in Singapore. So, but since that time, conditional marketing permits have been granted to a number of manufacturers, and so NIPT is available essentially within a private healthcare setting or equivalent on the mainland. So some similar concerns that we have already considered relating to whether women are properly informed, appropriately supported, and of course, important concerns with equity in access to this particular technology. So in Singapore, it's quite different from Hong Kong in a sense that you'd see, perhaps unsurprisingly, a more significant state involvement. So the Ministry of Health has from 2018 issued a code of practice. I was a member of the working group that was responsible for this particular code of practice under the leadership of my former colleague, Professor Denise Goh, and Dr. Tan Wing Han. So in this code of practice, you'd see quite a different approach from what has been proposed by Michelle and Ben. You see, whereas Michelle and Ben in their article focused on the informational aspects, in the code of practice, the focus has been very much on the test and the provider, so including the labs and clinicians that were that had to decide on what tests to recommend to the patient. So, of course, what you see currently, the code of practice is a good practice guideline, but it's expected to have regulatory effect once it's been implemented as regulation under a new legislation that's known as the Healthcare Services Act. So a very much more direct state intervention. So another feature that's quite different, as we'd see from Michelle and Ben's position discussing that in the US. So just very quickly in terms of what the code of practice considers. So here it speaks to the intent of the use of that particular technology, and then of course decision matrix being centered around that particular technology rather than just the sort of information. And you see a typification of the various types of technologies that could be used. Of course, NIPT would just be one of these. I thought that these developments highlight some important differences, again, relating quite well to what Ainsley has mentioned in terms of having to think about reproductive autonomy, its construction or its understanding in relation to the individual and its relationship with broader social values. So of course, it also raises, as Ainsley pointed out in her presentation, concerns with eugenics. So this has, on ethical fronts, been taken up in the discussion by Robertson, as you see, who has argued very strongly in favor of reproductive choice. Of course, Michael Sandel taking a somewhat different position, arguing that we should have a deeper appreciation for children as gifts, for example, things that we cannot or we should not try to control, concerns with hyperagency and the sort of mastery that we seek to achieve. So I thought this particular point is very interesting in thinking about the sort of approach that's taken up in Singapore, particularly given its technological focus and its attempt to use legal mechanisms essentially to achieve an appropriate balance between individual concerns and expressions of reproductive autonomy with broader social kind of concerns. So I thought Francis Cam's critique of Michael Sandel's position is especially helpful. So her argument, I thought, was very pertinent in helping us to think about whether we should focus on the technology itself or the intent behind the development of the technology and the sort of mastery that we seek to achieve, as well as the sort of value implications that could come from there. Of course, these would be some of the positions that she have put forward in response to Michael Sandel's argument for skepticism towards the use of something like NIPT to achieve mastery over one's reproductive destiny. But I thought what's especially helpful from Frances Cam's position is her indication of the technological impact on thinking about responsibility, especially the distribution of responsibility. So whereas, as we've seen in certain jurisdictions and arguments by certain scholars, this distribution of responsibility should be essentially confined to medical or healthcare professionals, healthcare institutions, and patients. I tend to think that given some of the concerns highlighted by Frances Cam, they point to the need, the very great need to have the state be involved in very important ways, and particularly in terms of facilitating a broader discussion, which even given the rather more public health or state-based approach, whether it's in Singapore or mainland China, we are still not seeing being done well enough. So here, for example, discussions as to whether these technologies should be developed in the way that they are, whether they should simply be left to commercial providers, and concerns with fair distribution of benefits, particularly where they could have implications on enhancement, the implications of making these changes, particularly within complex systems. So the sort of implications on population health, of course, remains a very big concern, as we have seen in quite a number of jurisdictions. Concerns with homogenization and the sort of ends that we could consider to be good through the use of ENIPT in systematic screening kind of programs, whether it's for Down syndrome or beyond. So some very important concerns here. I don't have any clear response to these sort of concerns in thinking about the social cultural context of Hong Kong or Singapore, and I tend to think that that there's quite a bit of space to develop. Just drawing on the term of mastery that Michael Sandel has used and the sort of limitations that we see here, I tend to think that we have to start considering within our jurisdictions, whether it's Hong Kong or Singapore, about the sort of mastery that might be acceptable over one's destiny and the sort of goods that ought to be achieved, how it ought to be, in terms of implemented, mediated through the social cultural context as well as the regulatory governance that we find in these systems, the technological capabilities that we are being confronted with. In fact, if we are to think about scaling up on ENIPT, it's very difficult to think of a situation where we could just simply leave this to commercial developers. So currently, we only have as far as I'm aware, one large-scale study, and that's the Trident study that's been introduced in the Netherlands. So it's very difficult to think about commercial developers on their own having access to these sort of information without otherwise having access to state-funded or state-led kind of programs, as we see in a number of other jurisdictions for a number of rare diseases. So in terms of thinking about the professional capability, I do think that looking specifically again at Singapore and Hong Kong, there are very serious resource limitations. So the ability of healthcare providers to just simply take this on themselves and to work out what sort of information, what sort of technology, how the technology should be applied in that particular situation, I think is simply just not good enough, particularly if our goal is to support women having to decide or make sometimes very difficult reproductive choices. So some of the concerns already highlighted by Ainsley in relation to equity and of course the complex system implications that Frances Cam mentioned in her consideration of Michael Sandel's arguments are also some very important concerns that I think will be very difficult to achieve just leaving the matter to physicians and clinicians or otherwise confining this within a very narrow clinical context. So almost coming to the end, looking ahead at the technology. So we have, or rather I should say, we are now confronted with quite a few concerns in thinking about ENIPT. I'm not sure if there are any clear solutions in place at the moment, but the technology itself, of course, as we find, is moving on. And now we even have preconception-based kind of testing. So even before you have a child, you could potentially understand some of the genetic risks that might come with reproduction and some of the risks that may be presented for your offspring. So, so with this, how do we think about relating these sort of developments with what we have in place? So we do have a scaling up in terms of the expanded information following conception, but also a scaling up in the other direction in terms of even before having conceived a child. So, so with this, just to conclude, I do think that there are some very important implications, and I think this audience will need no persuasion to say that we do need to consider some of the very serious ethical implications. But then I think what's extremely interesting for me will be to think about where laws and regulations will fit in, particularly if we want a system that could enable professionals to perform their responsibilities or duties well in the best interest of the patients, without question about that, and to ensure that women in particular are supported in terms of making decisions, sometimes very difficult ones, in the very situation that they find themselves. So, so as I've mentioned, there are no strong justifications to prohibit ENIPT, but I think there are very serious concerns with the inequities, whether in terms of access, and for that matter, once having had access to the ways that the information is going to be applied. So in thinking about the regulatory governance that we find in systems, so we have some of the more market-based approaches. I think that that sort of approach will be very difficult to sustain, thinking about how the technology itself is developing. I tend to think moving forward that a mix or more hybrid kind of approach, mechanisms that would seek to balance out individual concerns with public health or population health kind of concerns would be a more sensible approach. But even within these kind of systems that are very much focused on population health, that just isn't enough measures being taken up to engage with those that are those individuals who may be involved. So these, of course, by these, I do mean patients in particular, or women thinking of having children or making reproductive choices. So there are some very important implications on how we should be thinking about reproductive autonomy. I won't elaborate too much on that because my view, as I've mentioned, is not very different from that expressed by Ainsley. And so the key challenge now, particularly in the context of East Asia, is to think about how to mediate or to translate these sort of ethical concerns and positions into policy and practice within a clinical care setting and beyond. So with this, thank you so much for your attention, and I should be grateful for your thoughts. So it's over to Dr. Au, and I shall stop sharing. Thank you.
Yes, thank you, Calvin, for that very information-rich and also thoughtful discussion of the challenges and implications of the expanded NIPT and some of the philosophical thinking behind the different points of view. We will go into a round of discussion with commentators and then responses before we open up to Q&A sessions. So may I first invite Professor Catherine Hughes to make some remarks and comments.
I'm going to begin by thanking both Ainsley and Calvin for incredibly interesting and rich papers. I have a lot of questions and things that I'd love to discuss with you, but I'm going to try to limit myself to a couple of questions each. So first to Ainsley's paper. Ainsley, I particularly liked your way of framing reproductive carrier screening in terms of public health ethics and still emphasizing the role of reproductive autonomy within that. But I was curious how you think that importation of public health ethics could relate to the critique of, say, what's called the public health rationale for prenatal testing, where it's been described as a search and destroy mission in relation to prenatal testing. And I wonder if there's a way in which carrier screening just pushes this further into the reproductive process, or is there a way in which public health ethics kind of rescues it from that? It seems to me that solidarity, the value of solidarity, may be particularly double-edged in this context, where we see solidarity as really kind of building in that pressure of social norms, as well as potentially giving an option beyond that. In relation to your point about eugenics, this is obviously related. I really appreciated the fact that you actually went beyond that very standard bioethical response of saying it's just about individual choice and therefore not eugenics. We all know that that critique is inadequate. But it seems to me that your critique of eugenics is still somewhat pragmatic, in the sense that it's focused on how we do eugenics rather than a critique of eugenics per se. So, for instance, you pointed out that it relied on a narrow view of desirable traits, suggesting that if we just open that to a wider range, then perhaps it's okay. And similarly, focusing on inappropriate methods raises the suggestion that there are, in fact, appropriate methods of doing eugenics. So I guess my question then to you is, are there appropriate eugenic methods? And is carrier screening one of those? So I guess I'm pushing you to say, okay, there is an acceptable eugenics, or do we need to strengthen the argument against selection and eugenics per se to actually have purchase against these technologies? So that's Ainsley's. For Kelvin, thanks, really interesting paper. I'm particularly interested in this because I'm working on a project myself looking at expanded non-invasive prenatal testing in Australia, and we're particularly interested in that challenge of the comprehensiveness of information and what you do about counselling and consent process in that context, how women may be able to make decisions within that context. And I agreed with your critique of the Bayevsky-Berkman paper that it's insufficient just to kind of leave this question to medical practitioners. I suspect you can go a little further on that, because if you do that, thinking about Ainsley's very nice discussion of the complexity of severity, doctors will have very different understandings of what count as severe conditions. And if you think about this in relation as well of the context of very different abortion laws around the world, then that will have a very significant effect, or can have a very significant effect, on the exercise of reproductive autonomy in different contexts. So I think I'm right about this, that Hong Kong itself has restrictions on termination of pregnancy related to severe anomalies. And so how severity is actually described or discussed or understood there is going to make a significant difference if medical practitioners are themselves the people who are making decisions about what information should be provided. And it seems to me that that can really just involve a return to paternalism in disguise. But what I wanted to pick up on following that, just very briefly, is the turn to reproductive autonomy and enhancement at the end of your paper. Now, I have lots of points that I wanted to make about this, but I'm going to limit myself to two. The first thing is a very quick one. I have to disagree with your recourse to Sandel at this point, because it seems to me that in relation to prenatal testing, Sandel actually has really conservative implications, which is you should accept what you're given, accept the gift of life that is given to you, i.e. don't terminate a pregnancy, right? That's the ethical kind of implication, the normative implication. But I think there's actually there's a lot to be said about the enhancement literature and just how that really does translate over into the prenatal testing context. But I wanted to pick up on something a bit broader, which is that in all of these discussions, we make recourse to the idea, the concept of reproductive autonomy. But the real question is, what do we mean by that? What is reproductive autonomy? it seems to me that the debate on what reproductive autonomy is has not actually moved forward very much from John Robertson's claims, which you have pointed to, but they're really problematic. It's completely inadequate to understand reproductive autonomy as negative freedom in this context where you're talking about very comprehensive possibilities of information provision. And we have to ask those questions about what kind of support is needed, not to respect reproductive autonomy, but to actually realise it. And I'm going to stop there. Thank you.
Okay, thank you, Catherine. Those are really pointed questions, and I look forward to responses from AC and Kelvin. But time over to Josie.
Thank you for these really provocative presentations from Ainsley and Kelvin, and I think that they should also thank me, because I'm just going to fill in a little time here so that you both have a moment to think about hard questions that I just asked. All right, let me say I thought both papers were super interesting, and they are, they have a lot of synergy between them, but they're also really different in very interesting ways. So let me just ask a couple of questions related to Ainsley and the work that she presented. That's hers and from Lisa Dive. So first of all, thanks for working on this issue. I think it's a really hard question, actually. And it raises a lot of tricky issues, and you were really, really clear and, helped us, especially by breaking it into these 3 subtopics, which I thought was really interesting, about the sort of the relationship between public health ethics and clinical ethics or clinical decision-making, this issue around eugenics and this question of severity. And I think my question actually is about the relationship between all 3. And I found myself wanting to ask you to reflect on the rejection of eugenics as a description of what, at least part of what a carrier screening program would achieve. Now, I know that eugenics is, maybe it's such a bad word at this point that it can't be attached to something without it being just, sort of a condemnation of it. But it seemed to me that if severity is an important concept, then there is a sense in which the program has eugenic goals. So I wasn't able to, while I followed each set of arguments separately, I wasn't able to put them together in a way that didn't kind of point towards something like a eugenic goal, a reduction. Now, I get that you can roll out a program in a way that means that you do or don't emphasize your eugenic goals. So if you measure, for instance, as you were suggesting, how many people are offered the carrier screening rather than how many, the incidence of those disease, the conditions in the population, you have more or less emphasis on the eugenic goal. But I feel like that's about the way in which we carry it out, but not really about the underlying purpose of a healthcare system adopting a screening test. Now, you can probably put the things together for me, but that's what I was struggling with a little bit, is that relationship between the public health values or ethic goal, the ethics, the eugenic critique and the eugenic goals of the program and this issue of this severity component. So that's the hard work. And for me, the way to solve it is to accept that there are eugenic goals of a program like this. But that might, I'd be interested in whether you think that's an unacceptable sort of response. For Kelvin, I'm really interested to hear your response to Catherine's question about what reproductive autonomy is, and I think I was circling maybe around a similar question as you were talking. I would sort of add as an aside that I think it's when you work in the United States, as I sort of at this point remotely do, but as I did in the flesh for quite a long time, because the state of abortion is an issue in the United States, and the fragility of that of abortion access as a legal right in the US, it makes one very wary of having government involvement. So the state's role is quite problematic, even where there might be quite strong arguments for the state playing a role in, for instance, making sure that the healthcare system isn't overwhelmed by people who don't understand the implications of their test results, or protecting people from unnecessary stress in the course of medical treatment. So there might be these really compelling state goals, but because the state doesn't actually have a clear commitment to reproductive autonomy in the very sort of simple sense that Catherine was mentioning, in the sort of negative rights sense, even that isn't adequately, isn't a commitment. Therefore, it's like you can't really rely on the state in ways that, it's unfortunate that's the outcome. So you can sort of see why Ben and Michelle might want to veer away from anything that that relies on the state actually caring about reproductive autonomy, even in the most sort of basic sense. But I think that that kind of made me want to know a little bit more about how you understand this commitment to reproductive autonomy on the part of government or states. So, then we could ask ourselves, if we were a little clearer on what reproductive autonomy, to what extent a state was committed to it and why, if it was something that NIPT or expanded NIPT can actually promote, and in what ways, and we would be able to assess a program against that a little bit more clearly. So that made me think that probably I just want to know more about what you mean when you talk about regulatory attitude, I think it was, or regulatory cultures, and whether or not you see reproductive autonomy, however you understand that, as being a healthcare related goal that a state might have, or a sort of a separate kind of freedom or well-being or equality related goal. So where it fits in the kind of priorities that a state might have might tell us a little bit about the extent to which a state would be willing to sort of go to bat for it in terms of assessing something like a prenatal test. So I would love to know more about how you think about that and where you place that goal in kind of your understanding of the state's interests, I guess.
I think it will be a bit of a tall order to ask Ainsley and Kevin to respond each in 5 minutes to those set of questions. But let's make an attempt. Ainsley, first to you. Do you want to explicitly address the eugenic goal issue, or can it be done coherently?
Yeah, I mean, I just want to say thanks. They're amazing questions. And I'm going to completely fail to answer them in any adequate way. I think the other thing was I was attempting here to sort of present a body of work that's taken Lisa and I 2.5 years to do in half an hour. And so obviously lots of little nuances and footnotes and asides were left out. I think though, Catherine, your knowledge of the literature and the sort of status here just shines through, and the prevention paradigm, or the seek and destroy kind of aspect, Lisa and I certainly considered that when we were talking about this. But the way that we structured our argument kind of meant that we just segued quite shiftily around it, actually. We sort of, I don't know if it was that we kind of thought it was too hard or if it was irrelevant, but in the end, we ended up writing this paper without really tackling that head on. I think part of it might have been that there is already another paper in the literature that directly compares the prevention paradigm and reproductive autonomy. We didn't want to be accused of not making a novel contribution. But other than saying we sort of got our way around it, that's not particularly adequate answer. I think your comment on solidarity is really interesting, because I think I see it very much as solidarity with people whose lives will be impacted by screening, I guess. I didn't see that slightly sort of darker aspect of it, and it's interesting to think how far that concept would go and if it would be useful in that context. I should add, like all concepts in bioethics, solidarity is the subject of numerous fights in the literature, and lots of people who completely can't stand each other's versions of this concept. So we went with a particular understanding of solidarity, which if you don't follow that understanding or disagree with it, it might mean you come to a different conclusion. But I do think, just to make some attempt about the seek and destroy aspect, I think this idea of pluralism that we landed on in our paper is one in which, you know, you just never get to the point of the goal of screening being to seek and destroy. The goal of screening is much broader and more nuanced than that. And actually, it's about protecting people's ability to reflect on their individual values through accessing, you know, good quality support, which isn't just accessing information. It's actually the ability to turn things over, to think about it, to work out what kind of lives they might like to have and how. So, you know, we even went as far as identifying 1 or 2 papers that make this claim explicitly. They're quite hard to find, but they are out there. And in the end, it sort of ended up not being highly relevant to the paper we wrote, but I'm not saying that it's not relevant. So that's a very fudgy answer to that question. Again, with the eugenics aspect, we actually got pushed quite hard on this by a reviewer who said, you asked this paper about responding to eugenics critique, and yet you never really quite say. You sort of skirt around it, but you nearly quite say. And so we sort of split it between actually eugenic in that, you know, definitely reducing incidence, and the leads of Mackenzie's mission were quite clear that due to things like the Hardy-Weinberg equilibrium and spontaneous arising of new variants, you know, these conditions are not objectively going to be impacted by screening for them. But so what we ended up saying was, yes, you know, we need to recognise that this can be eugenic. And I think in some ways that sort of slightly answers Josie's point as well. But what we say is that our position on what we can do about it is what's more important. So we really needed to say the challenge is not to sort of justify eugenics or not, but it's to try and do everything possible to head off that critique by making the program you know, designed in every possible way to respond to that critique. It's not going to make it go away. It's not going to endorse it. It's actually just going to kind of live with it without necessarily making a value judgment one way or the other. Because I think I can still remember the words of Angus Dawson when Lisa and I were presenting this as a work in progress. You know, he sort of said, do you really want to be associated with a paper on eugenics? Okay. And, you know, when this paper came out, I was just so anxious watching Twitter, you know, really scared that we were going to get shot down. But I think, you know, we really tried to take that critique seriously and to think very carefully about how a program could simultaneously exist while that critique was there, and to do that in a productive way. So our point wasn't really to sort of knock down the eugenics critique. It was to sort of make this program happen at the same time as that critique going on. But to sort of try and answer this question about whether there are appropriate eugenic methods, I would like to think not, in the sense that, well, not at least in a very straightforward understanding of eugenics. I think you'd have to look at how you're defining this concept, but I also think it is such a difficult concept to discuss in a sensible and rational way, and it gets used in so many different contexts. And so if you are going to in any way attempt to say that there is appropriate eugenic methods, you need to be extremely careful about the definitions that you're using and the methods that you're endorsing. And so we talked more about the critique rather than the concept itself, and that was how we tried to productively and positively get around it. We're all about the middle nuance here, and but actually sometimes you get reviewers that they're at extremes, you know, A and Z, and you're in like J, and it can be really hard to keep your reviewers happy. I digress. That's peer review. So I've gone a little bit over my time. I'm sorry, but with Josie, I think your question is just so well timed, because we're kind of coming into the final sort of 6 months or so of this project. And for me, I think it's an attempt to tie these three things together. I mean, we've picked off these sort of papers one by one as we've gone through, and we've tried to write them all in a way that is accounting for both the bioethics literature, but also accounting for the fact that this is a real thing that is actually happening in Australia at the moment. And what we're writing about is going on, and people are going through it at the same time that we're writing about it. And I think your comment about severity is really interesting because, severity is often used as a way to try and avoid critiques of eugenics, because it's like, no, we're not being eugenic because we're only talking about things that are super duper serious, and that, everybody would completely endorse as not wanting to be something that you would want to put someone through, even though it might mean, or does mean, that that person won't exist as a result. And obviously, if you're talking about pre-implantation testing or prenatal diagnosis, your answer to those two things might be slightly different. But I think maybe what brings it together is the relationship between reproductive genetic carrier screening and the social norms that influence both the program and the society in which the program happens, and looking at the interplay of those two things and tacking onto that questions around decision making and who gets a seat at the table, and the transparency of deciding what it is that is screened for and how, and just ensuring that at every point those things are being done really seriously and carefully. I think ultimately, we wrote the public health ethics paper first before tackling the other two, and they all sort of do start to smush together a little bit towards the end. But ultimately, what we're trying to say is that, we have this program definitely has value. This program is strongly desired by individuals and couples. It's strongly desired by health professionals. None of those desires are completely unproblematic. And it's about ensuring that those desires are informed by high quality structures of the program and high quality opportunities to really reflect on values, both individual and social.
Kevin?
Thank you so much. So a note of grateful thanks to Catherine and Josie for those great points. You've given me quite a lot to think about. So I think I'll fare even worse off than Ainsley. I haven't got her intellectual prowess to fall back on. So just a quick response, and of course very interested to hear your further thoughts, particularly Catherine, in terms of your work that's being done on ENIPT in Australia. So that will be brilliant if there'll be some follow-up conversations. In terms of your recommendation to look into how severity is being understood, that's something that my colleagues and I are actually in the process of looking into. Thanks, of course, as you've mentioned, to Ainsley's research in this space as well. So I think what's fascinating, and that goes into the sort of situation that we find ourselves in East Asia. So I think that will be very much in response to your point, Catherine, and also Josie's, in terms of what I understand to be reproductive autonomy. So just to be clear, and thank you so much for highlighting some of the inconsistencies or difficulties that I've made in my arguments. I am in fact very much for John Robertson's position, as you've noted. So I am therefore very much in favor of Francis Cam's critique of Michael Sandel's position. However, I think, that said, I tend to think that we need to draw, at least in the context of East Asia, more of concerns in equity rather than solidarity. So that goes towards Josie's point as well. So my own sense is that in the context of East Asia, unlike the US, so in the US, as I understand it, that there's quite a bit of ideological forces at work, particularly around the abortion debate. In East Asia, we tend to have less of that, at least looking formalistically at the regulatory governance that we find in East Asian jurisdictions, or at least the three that I've been looking at, i.e. Hong Kong, Singapore, and mainland China. So in contrast, there's a much stronger economic factor there. So, and how they get translated in terms of cultural expectations, cultural expression, and the way that women live out their autonomous decision-making capability on reproduction, I think is fascinating, and it's very difficult to generalize at this point. But what I can say is that what NIPT and eNIPT in particular are starting to make very clear will be the sort of inequities that we find. So some women having the ability to live out the sort of values that they see themselves or that find important to their overall well-being and their overall goal in life, as opposed to some others who just simply haven't got the ability to even consider some of these possibilities. So therefore, I do see a very important role in law and regulation to try to, in a sense, level up, especially for women not having the capability to even consider the sort of possibilities that the technology itself may present. And I also tend to think that thinking very carefully about the sort of governance structure is very important to avoid the homogenizing effects of the technology, and also, as Catherine mentioned, the very real risk of paternalism or return to that, where we do not currently find, at least looking at in a very formalistic way, the sort of legal regimes that we have in these jurisdictions. And I think that the social political context will be increasingly important, given that all three jurisdictions are faced with rapidly aging population. So on this, that particular consideration will also weigh heavily in terms of how women think about their reproductive role and also the well-being of their offsprings moving forward. So thank you so much. Lots for me to think about, and very, very grateful to all your comments, and of course also to Dr. Au for this wonderful opportunity. Thank you so much. So back to you, Dr. Au.
Thank you, Kelvin. Presenters and discussions are okay. I'll allow the seminar to overrun by maybe 10 minutes. So we are actually now behind by about 10 minutes. So allow some questions from the audience. Let me invite the audience who may wish to comment or raise questions to type in your questions. I try to keep it brief, and then I'll ask the presenters and discussants to respond. There is a first question that came to me separately, privately. It is related perhaps to Catherine's point about support as being important when you talk about reproductive autonomy. But I think she phrased the question more strongly, and that is does it make sense, or is it even ethical for the government to leave to laboratories and clinical services to offer expensive prenatal testing to women without necessarily having the adequate support system or even the general literacy in the population of the topic of the subject? So what would be your response? Kelvin first, and then I'll invite Catherine and Ainsley and Josie to. Does it make sense, or is it ethical?
Yeah, okay, thank you so much. So yeah, so as I've mentioned in my response to very instructive and thoughtful comments from Catherine and Josie, that I do see that as ethically highly problematic. So we see the inequalities, not just in terms of access, but even among women who have access to their capacity to deal with all these sort of information. So I don't think that there is adequate consideration. And I do think that there is a lot of space for the state to become more involved, not so much in terms of pushing its own agenda, but in terms of thinking about how the capacity or the capability of women to deal with well, very difficult reproductive decisions and choices, right, in that sort of setting. I'm not sure that we have even started the conversation. And here's where I see the professional organizations as having a particularly important role. So rather than just to simply say that it should be a matter that's left to clinicians, I do think that clinicians should think about how to create forums so that women can better express their choices, their decisions, their concerns, and highlight the sort of support that they can have, particularly in terms of the economic ones, where I do think that the state could have a more prominent role in meeting. So, thank you.
Yes, that last point I think is very helpful. And Ainsley, we can't often start a program in an ideal society where people are informed, literate, and the supports are ready. Sometimes we just have to start a program when things are not ideal. So, but is it ethical to leave it to to the system to adjust to the technology?
Yeah, I mean, I'm interested in that question both for NIPT and reproductive genetic carrier screening, but I will confine my remarks to RGCS given the content of my talk. This is a live question in Australia at the moment because screening can kind of happen in various ways depending on funding models. And so this is not, just very broadly, you could make public funding available and then allow anybody who meets the criteria for the funding to offer it. So you could have a range of different private sector entities offering testing, or you could have public funding available, but through a different modality such that everybody gets the same test offer, that the test is very standardized, there's centralized collection of information, etc., and a central information suite. And that would probably best model what the Mackenzie's Mission Project is currently doing, which is everybody has the same experience. I am sure there are excellent commercial entities offering reproductive genetic carrier screening. I'm also sure that there are lots of entities offering very non-excellent reproductive carrier screening. And so I tend to have skepticism generally about commercial involvement in healthcare, particularly for things like this, where there can be significant complexity in light of results. And so I wouldn't necessarily say, something is ethical or unethical. I tend not to use that kind of vernacular, but I would definitely say I would much prefer when it comes to things like this that can generate moral complexity, that they are offered in a context where the process is designed to support people to make a decision that suits them as much as possible. And that would include, after test support, most importantly as well, because some of the problems, I think, when testing is allowed to develop in the private sector without much oversight, is that tests are given even when it's not appropriate because there's money to be made. And then the people who have those tests end up coming back into the healthcare system to kind of mop up the after effects of that test. I also think a formal centralized approach is better because the genome is dynamic, and this information that we're providing at this point in time might not always have the same meaning, and it will allow better follow-up in the future if resources allow. So, but I think it isn't that simple in reality because of how our health systems are set up. But ultimately, I would rather have more centralized control than less. And that may make me a paternalist, but I don't mind that very much. I'm okay with that.
Okay, Catherine, you have anything more to add to that?
I don't have very much to say, except that I agree with what Ainsley has said. I mean, I think it's an extremely interesting question, and I would say that providers do have a moral obligation to actually ensure that people having tests are informed and do understand what those tests mean. I think that's a fairly standard moral obligation for medical practitioners, actually. And I think as soon as there's public funding involved, then the government also has an obligation to ensure that there's a high level of genomic literacy amongst its population. I think that's a really difficult challenge when you're kind of dealing with highly various populations like in Australia, where you are trying to kind of raise genomic literacy and genetic literacy in very diverse communities. So it's no easy kind of solution, but I think that's what the general obligation would be.
Okay, thank you. Let's just take one final question. and that is related to eugenics. The question is, when we talk about, sometimes we talk about collective values as being a reference in rolling out programs or designing programs. But we're also aware that in some cultures or countries, perhaps eugenics with a different history than Europe or the Western countries does not have the same negative connotation. For instance, in mainland China and perhaps also in Hong Kong, if you translate eugenics literally into Chinese, it's actually a positive term to make future life better, future species or life better. So if you are in a culture or society where the collective values are not that on guard against eugenics, does it make it more acceptable to roll out a program like the reproductive carrier screening and population level?
So a nice simple question to finish on then. That's a fantastic question, and I think it brings in some really interesting questions around pluralism, but also perhaps cultural relativism, neither of which, well, particularly the latter, I'm certainly not an expert in. And I also think it's about, is it more important to talk about the definition of a term, or actually is it more important to talk about the procedures and processes that that term gives rise to? And I do think it brings up really complex considerations around, I guess, political systems in which these decisions get made and whether those systems are acceptable and how the individuals themselves in those systems perceive them and what freedom they have to actually critically reflect on their place in the world. So I think it is really important to take a concept and think about it in its local context. I also think that doesn't mean we should shy away from asking whether the practices that concept might give rise to are acceptable, even if it might grate against what is like a perceived local approach. I think there are, I'm not thinking that RGCS is one of these, but I do think there will be universal practices that could be condemned, and saying that they're accepted in one context doesn't necessarily mean that that's okay. So yeah, I think, certainly the eugenics literature has been dominated by interpretations of the concept that have probably come from so-called Western scholars, I would think, like a lot of bioethics. And it might be that actually there's a need for further scholarship to critically turn this concept over in light of different cultural approaches and see what happens.
Any other comments?
Yeah, thank you so much for that point. Just to add to what Ainsley has mentioned, my own sense is that thinking about the term in East Asia, I think it's under-considered and certainly under-theorized. So particularly if we were to think about the situation of women across East Asian jurisdictions. So many of them now have, I'm not saying all, this, of course, this again relates back to concerns with equity. So for some women, they are able to have or to think critically about the sort of lives that they want to live. And I think this will have very important implications about what betterment of your future offsprings would be like. So of course, women now also have the choice to decide not to have any offsprings at all, or not to exercise their reproductive capacity. And I think that's important. So what I see lacking in the East Asian jurisdiction is to make explicit some of these implicit assumptions and to actually talk about them in a sensible and reasonable way. So otherwise, there'll be lots of implicit cultural assumptions on the part of clinicians on the one hand, and then of course, women and their families on the other. And this, I think, does not support our cause in promoting reproductive autonomy. So I think this is where I do see as an important space to develop in the context of East Asia. So thanks so much again for the
This is great, Kevin. By way of closing, thank all the speakers in the discussion for this really, really rich and truthful discussions. We never have enough time for this kind of discussions, and I hope to see you again next year sometime in some forums to continue the dialogue. So thank you very much for participating and all the audience. Thank you very much. Have a good day.